since you're on your headphones, you're a bit muffled, but if you speak a bit louder, it will be okay. It should be okay.
Okay, so I can speak louder. You
Yeah,
can see my slides
we yeah,
in full screen.
yes, we can. It's not full screen now. It's still your view, so it's not, but it should be fine once you change to presentation mode. Yeah. The important thing is that we can actually see your screen. Yeah.
Do you see my slide?
I can see your slides, but I
But not
see
in full screen.
not in presentation mode. I see them as you see them when you select them.
Moment. I don't know how to make it full screen.
Slideshow. Go to slideshow. Go up first line.
Yeah, moment.
Yeah.
Moment.
So not the first line in the menu, but the second line. There is file, home, in design, whatever, and then
I know, but I can find the button. Let's see. You see my slide.
yeah, in the end, it's not a big issue if we see, but we can see the other slides as well. So if you change to slideshow, it
Slideshow. I
should,
know, I know.
yeah.
I know, but I cannot find the button in a moment.
No worries. We still have a couple of minutes, and even if it doesn't work like that, we can still see the information. So
But anyway, if I cannot change into slideshow full screen, you can see my slide too.
yeah, we can go ahead like this if you can't change it, no problems.
Yeah, I think because a moment, I don't know what to make.
Good. So I think colleagues are still joining.
Do you still see my slide now?
It's the same thing. I can see your slide, but it's not the slideshow. It's the present more or less the your view, your screen where I can see your slide and I can see on the left side the rest of the slides.
I understand. A moment, I will ask for help.
Yeah, well, it's not a big issue. Until then, I will just
Alo,
start with saying
Khoa đang ở đâu vậy? Không biết rồi, anh biết rồi.
I will just start with saying thank you to you and your team. It's a pleasure to have you with us today, to our academic sessions. I know that your hospital is really impressive. We are looking forward to learn from your experience. It's great to have so many of our colleagues with us today. I'm pretty sure they will be really impressed about what you're doing, and we will hopefully have a good session today. I can see we still have people attending, which is good, but probably we will start in a minute. While you're sorting out things on your side, I will ask Professor Dana Prangasam to kindly introduce Addenbrooke's and the Cambridge University hospitals and our department. So, Professor Huang, can you please unshare your screen? Thank you. Vincent.
Yeah, let me
Thank
just
you.
share going. Okay, can you see that okay?
Yeah, perfect. Thanks.
So, Lauren, thank you very much, and a big welcome to our colleagues from Vietnam. Xin chào, because I had the pleasure of visiting Vietnam literally about 6 weeks ago, actually. So it is really great to be able to connect with you again. Vietnam is a hugely impressive country on many levels and many
Recording in progress.
which what seems like a very small amount to us these days, but was quite a big amount back in the day from a chap called John Addenbrooke's. And that building you see still stands and is now a business school. Today, it has grown into one of the biggest biomedical campuses in all of Europe, housing many famous organizations, including the MRC, LMB, and of course, if you know anything about Cambridge, it churns out Nobel Prize winners of all sorts. But the hospital itself has also grown from small beginnings to become a major trauma center and a specialist center in the east of England area, covering all kinds of diseases. And as I've mentioned, it's got strong links with the university through academic roles such as myself and other colleagues, and in research as well as pharma industry. So, as mentioned, we're a large teaching hospital. We have 18 consultants, and we've got quite a large number of specialist nurses, surgical practitioners, and of course, junior colleagues. Those terms, three SCFs mean senior clinical fellows, SPR means registrars, JCF is junior clinical fellows, and FY1s are what used to be called as house officers. We are a very busy unit in terms of UK terms, though perhaps pales in comparison to what you guys do. About 750 major surgeries per year. Ironically, we actually don't even have a urology ward. We've got sort of half a ward or some beds on a ward, but that is used to its highest capacity to churn through a workload, but a lot of day case work. We have a very strong benign urology team, which is involved in research and academic department, as mentioned, primarily focused around renal and prostate cancer research. Our benign urology teams cover a range of things, including reconstruction, obviously kidney stone and disease, and also lower urinary tract symptoms. We have specific consultants who specialize in these areas, providing very high quality service and leading much of the national discussions in the UK around optimal and new managements. In terms of cancer, we are a cancer center for the East of England, which means that we provide the major surgery for bladder cancer, kidney cancer, and for prostatectomies, as well as our own pathway for diagnostics in terms of working patients up to diagnosis and management. And a number of us who are quite highly specialized in these areas. So I think that was all that we had to say. Together we are Cambridge Urology. And one of the key things we've been able to do is to focus on MDTs or multidisciplinary meetings to try to standardize our management of patients. And that is done through a number of multidisciplinary team meetings, including in prostate cancer, kidney cancer, bladder cancer. But we also have multidisciplinary meetings for stone diseases and also reconstruction as well. Particularly, we have to involve different colleagues to manage different aspects of reconstruction. In terms of our governance, we have fairly strict protocols and guidance which we follow to try to make sure patients get the same level of care. And this is audited through monthly governance meetings. And we also have an excellent and superb teaching program led by Lorian here today with colleagues from around the world. We're looking forward to the meeting today to add to that. As mentioned, our primary areas of research are around prostate cancer, particularly early cancer management, diagnostics, and management of early disease, kidney cancer, also in a similar area. Stone disease, particular strengths include to management, patient-reported outcomes, and metabolic disease, and also a number of different avenues of research in bladder and in tissue engineering as well. So I think that's all I was going to say, Lorian. I'll hand back over to yourself to chair. And again, welcome to our Vietnamese colleagues to this meeting today.
Perfect. Thank you very much, Vincent. I'm going to ask now Professor Huang to introduce his hospital and his team. I'm looking forward to listen to this. So, Professor, can you please share your screen? you're muted. You'll have to unmute yourself as well. Okay. Can you unmute yourself, please?
Can you hear me
Perfect.
now? Okay.
Yeah. Okay, we still see the same view, but that's fine. We can see the slides and it will work. It will be fine.
Okay.
Yeah,
I'm
don't get
sorry.
stressed about it. It's
Mhm.
we are happy with it.
Sorry, because I have a problem. I just want to introduce my center. Bình Hospital is a leading center in general surgery and urology nationwide in Vietnam. It is the first-class surgery hospital specialized in general surgery and urology, tutored by the health department of Ho Chi Minh City. And you know, the Ho Chi Minh City is the biggest city of Vietnam with a population of about 8 million people. And Bình Dân is a teaching hospital in surgery for three medical universities. It is the Ho Chi Minh City University of Medicine and Pharmacy, the University of Tham Ngọc Thap, and it's also the teaching hospital for the medicine faculty of Health University of Ho Chi Minh City. In urology, Bình Dân Hospital has a great degree of respect for the advancement of urology and also andrology. This urology compartment has 8 subspecialty departments: endourology, oncourology, endoscopic stone surgery, Department of Female and Functional Urology, Department of Andrology, and the Department of the General Urology A, B, and C. And we have 2 other units, the ESWL unit and one urethroplasty unit. The Department of Andrology has 30 beds with a well-equipped laboratory. And the urology compartment has a total of 410 beds out of 910 beds of the whole hospital, with about 80 practicing urologists. We have one SI Da Vinci robotic system for urology and general surgery. And the urologic robotic procedures accounts for about 3/4 of the robotic procedure of the whole center. Using the one robotic system since 2016, the urologists perform 200 to 500 robot-assisted procedures per year, and the accumulated cases are now around 2,600 cases. We perform the radical prostatectomy, the radical cystectomy, substitution cystoplasty, partial nephrectomy, and pyeloplasty, etc. We have a lateral endoscopic training center in general surgery and urology, with which we have organized 2 collaborative training courses with the European School of Urology. The one course of the urology masterclass in 2019, and secondly, the endoscopic stone treatment, the SD1 in last year, and it was taught by Professor Lorian Dragos. Thank you very much.
Thank you very much, Professor. You've been very modest and very quick with presenting things, but I think I can speak on behalf of all my colleagues. This is incredible, impressive. I mean, 410 beds only for urology. This is overwhelming for us in terms of. Now, can you please let me know, because I remember how things were run when I was there with you. But how many procedures, how many operations per day are you doing there, approximately on average?
And the whole for the whole center, we perform about 160 cases for the general surgery and urology. But for the urology, we could perform about 80 to 90 cases, urology cases per day.
Per day.
Yeah.
Incredible.
As you have once, I think you have one visited the department of the endourology of the operating theater of endourology, and I showed you how we perform the ureteroscopy and the therapy, etc. Yeah.
Yeah, no, it is for us in Europe. It is almost your numbers and the size of your center is very difficult to comprehend or understand. So that's why, as I said, I think it's extremely impressive. Now, thank you for joining us again. Thank you for introducing your center. We are looking forward to learn from you, and I would like you to start your presentation, please.
Okay. You see my slides?
Yes, we can see your slides.
Yeah, I can continue by that. I can go on by that.
Yes, I think so. I think Dr. Doan Tan wanted to say something. Am I right? Please unmute yourself.
Dr. Toan.
Yeah, before the lecture of Professor Huang, I want to say hello, Dr. Vegas. And I have some data about the young hospital at Professor Huang. I told you about the number every day in Young Hospital. For example, we have endoscopic diagnosis around 40 to 50 cases a day. Endoscopy procedure around 60 to 70 cases a day. BCNL around 15 to 20 cases a day. Robotic 1 to 2 cases a day. And laparoscopy around 50 cases a day, and open surgery around 10 cases a day. Totally more than 150 cases a day. Yeah. A lot of patients operated a day in my center.
It is amazing. It's really impressive. Thank you very much, Dr. Doan Tan. It's a pleasure to see you again. Professor, can you please carry on with your presentation? Thank you.
Yes. Now, can you still hear me well?
We can still hear you. We are seeing your screen in the same way, but that's fine. We can just carry on. We can see your slides.
Yeah. Thank you. Ladies and gentlemen, today my talk is about comparison of robot-assisted radical prostatectomy versus laparoscopy radical prostatectomy at the Bình Dân Hospital. For the introduction, you know that the RP is the cornerstone in the surgical treatment of localized prostate cancer. At Bình Dân, the RP was performed initially by open surgery, after that by laparoscopy, and since November 2016, robotic was performed at Bình Dân, and since then, the RARP accounts for nearly 50% of robotic cases after 1 year. The question is, when we practice the robot, we have the question of what are the advantages and disadvantages for surgeon and for patients of ARP versus LRP. So we conducted a comparative study from January 2019 to December 2020 to assess the safety and effectiveness of RARP versus LRP with the study design of a prospective non-randomized study, comparative study, to compare the early outcomes of RARP versus LRP. For the material and methods, based on the outcomes of the study with a similar design of the foreigners authors, we calculated the patients for each group of 41 patients for each group. For the material and methods, inclusion criteria are the patient admitted to Bình Dân for surgery, either RARP or LRP, for organ-confined prostate cancer patient with up to the minimally invasive prostate cancer, up to the CT3B with neither signs of lymph node metastasis or distant metastasis. The sampling was a convenient sampling. The patients were enrolled into two groups, RARP and LRP, with no randomization. There are two team of surgeons, the team of RP and the team of RARP, because the RARP was just begun since 2016, and we had 6 surgeons performing robotic. By then, only 2 surgeons had performed more than 30 cases, and 4 other surgeons at that time performed less than 30 RARP cases. For the operative instrument, we have the robotic system, Da Vinci SI system. The procedure RARP was performed by transperitoneal anterior approach, and the LRP was performed using the retroperitoneal anterior approach. We used the 6-port procedure, and the patient was positioned in the trunk de Lambert. And for the robotic, we followed the 13-step technique according to Lee. In post-operative management, the oral food and things were allowed in day 1. Post-op, the drain was removed when dry, narcotics and or acetaminophen. In post-operative recovery, and the patient was discharged in day 2 or day 3 post-op, or by the patient's willingness. The means of measurement, we use the IIF5 questionnaire for preoperative evaluation of erectile function. In post-operative, we use the visual analog scale, the Clavier window classification for surgical complication. In follow-up, up to 1 year, we use the Clavier window classification, IIF5 questionnaire for urinary incontinence diagnosis, and the SF36 questionnaire for the quality of life patient. And here are our results. For the patient demographies between the two groups, there was differences between the two groups in BMI and the prostate volume, in which the BMI and the prostate volume in the RARP group were bigger than those of the LRP. The clinical state of the two groups were not different. The perioperative variables, we have the differences in the operating time and the amount of transfused blood in favor for the RARP group, as shown in this table. For other perioperative variables, in the robotic group, we perform the nerve sparing technique, the Rocco stitch, and pelvic lymph node dissection more often in the robotic group in comparison to the laparoscopy. Post-operative variables, there was differences in the bowel movement recovery, brain removal, and post-hospital stay, which are in favor of the RARP, but the surgical margin was more often in the RARP group, unfortunately. And in the post-op cancer stage, it was similar between the two groups. In post-operative variables, we found a more positive macroscopic pelvic lymph node in the robotic group, and there was a difference in post-op pain score in favor for the RARP group, as you see in this table. For the complication, post-operative complication, the early complication earlier than 6 months, and at 6 months to 1 year, we found a high rate of complications in the LRP group, although not statistically significant, but is clinically significant with the retreatment of endo-incision of the bladder neck. For the functional outcomes, there was differences in the incontinent score 3 months post-op, the number of pads in 3 months post-op, and the IIF5 score dropped in 6 months post-op. For the quality of life, using the SF36 questionnaire, the robotic group is better in the laparoscopy in physical functioning, role limitation due to physical health problem, role limitation due to emotional problem, energy fatigue, and general health perception. For the discussion, comparing the patient demography between the two groups, there was no difference in age, comorbidity, pre-op, ASI score, pre-op, Gleason score, serum PSA, and clinical TNMA of the TNM of the cancer. But there was differences in pre-operative IIF5 score. The Arab has higher score than the LRP. BMI of the RARP higher, and the prostate in RARP was higher than the LRP. The perioperative variable of the two groups, there was no differences in conversion rate, performance rate of bladder neck preservation technique, blood loss. In terms of the blood loss, there was a trend of blood loss in the RARP group. In terms of the hemoglobin drop, blood transfusion rate, and amount of transfused blood. There was the differences in the two groups in perioperative variables. In the RARP group, we perform more the stitch, more pelvic lymph node dissection. The operating time is shorter in the robotic group, but unfortunately, we have the more positive surgical margin in the robotic group, and the nurse bearing technique we perform less in the robotic group. There was no differences in two groups in post-operative in recent score, PTNM, post-op complication, and post-op hospital stay. The differences between the two groups are the drainage time. In the RARP group is shorter, and the RARP group has less pain score. In follow-up at 3 months and 6 months post-op, there was no difference between the two groups in post-op incontinence at 6 months and 3 months and 6 months. The number of diaper in 24 hours in 6 months post-op, no difference, and the IIFI score drop 3 months post-op. The robotic has a big drop. Then the no difference in the IIEF5 score drop in 3 months post-op. At follow-ups, there were the differences in two groups in terms of the complication after discharge. At the moment of earlier than 6 months and after 6 months, the LRP has more post-op complication than the robotic group, although not statistically, but the LRP has three cases of Clavian 3 complication at 6 months post-op and at 6 months to 1 year post-op. And the number of diaper used at 3 months post-op, the robotic group has used less diapers than the LRP. And the IIEF5 score drop at 6 months, the robotic bigger than the LRP, especially the questionnaire, the quality of life at 6 months, the robotic group has better quality of life. Comments on the safety effectiveness of robotic versus laparoscopy. The safety of the robotic, it has the strong point of tendency of blood loss, although not statistically significant, given that the prostate volume of the robotic is bigger and the BMI of the robotic is higher than in the laparoscopy group. And another strong point is the shorter operating time, less pain, and the complication after surgery, 6 months, 3 months in the robotic, less than the laparoscopy group. The effectiveness of the RARP, it has the same rate of low urinary tract function preserving surgery, or more than that of the LRP. The robotic perform a more pelvic lymph node dissection than the laparoscopy, and the robotic had the shorter draining time, and in post-op urinary continence, there is a trend of the robotic group to recover continence faster than the laparoscopy group. The two weak points of the robotic group is the higher positive surgical margin in the robotic group, and the post-op preservation of erectile function less than the laparoscopy group at 3 months and 6 months in post-op. We can explain these weak points because in the robotic group we perform the nurse sparing technique less than in the laparoscopy group, and the low rate of nurse sparing practice in the robotic group may be due to the higher CT3 in this group than in the laparoscopy group. But when considering the two subgroups of robotic nurse sparing and the laparoscopy nurse sparing, the post-op drop in IIFI score at 3 months and 6 months was the same between the two subgroups. And for the conclusion, RARP versus LRP, according to our study, RARP is a safer procedure with less complication. It's a more radical treatment, a more lymph node dissection. It's more effective with shorter operating time, trend of less blood loss, drainage time, less pain. It has better functional outcome in terms of urinary continence. It has better quality of life. There are two things to be improved, the surgical margin and the the nurse sparing technique must be practiced more to preserve the erectile function. Thank you very much.
Thank you very much, Professor. It was quite interesting to listen to you. So we will open this topic for discussions and for questions from our colleagues, from all attendees, but it's going to be a bit difficult for me to see who would like to ask questions. So there is a tool where you can raise your hand, and if you raise your hand, then I will, just allow you to speak. And I would really like this, if possible, to be as interactive as possible. I would strongly encourage our colleagues from Vietnam, younger colleagues, to ask questions. Don't be shy. As you can see, I'm not. My English is not perfect, so language should not be a barrier. As long as we don't expect anyone to have a perfect English or to address the perfect question, but it would be good to learn, and the only way to learn would be by asking and discussing. So whom should I start with? I'm pretty sure that my friend and colleague Saiful Mia, who is a robotic surgeon here, would like to ask something. So I'll start with Saiful, but then I'm really looking for a few of our colleagues from Vietnam to get involved in the discussion. Thank you. Saiful, go ahead, please.
Thank you, Professor. Wonderful presentation, and thank you for sharing with us. A couple of points. I noticed your BMI in your patients is very low compared to England. I think your average is 22. I've not seen a man of BMI 22 in my local practice. How experienced were your laparoscopic surgeons? Certainly, I tried laparoscopic many years ago, and I'll be honest, I couldn't. It was very difficult. I mean, I've still got nightmares remembering trying to do laparoscopic prostate, especially suturing. But how experienced? I mean, how many years of practice have you been doing laparoscopic?
Thank you for your very interesting question. And as in one of my slides, we began laparoscopic radical prostatectomy since 2004, and it was a pioneer by our senior professor. At that time, I was assistant to this professor, and he performed. He was the first surgeon who implemented laparoscopic radical prostatectomy using the extraperitoneal approach. And for the extraperitoneal approach, he used a dissecting balloon, a homemade dissecting balloon, because Vietnam is still a developing country. We don't have so many instruments, so we use for the retroperitoneal laparoscopy. We have to create a working space using inflating balloon. And we use the hand-up glove to make the inflating balloon and to create a working space, and then to place the ports. And by that approach, he and his team and I was his assistant to perform the retroperitoneal laparoscopic radical prostatectomy, and we have quite a lot of experience of laparoscopic radical prostatectomy, and only since November 2016 did we practice the robotics. But when we practice the robotic, we use the intraperitoneal approach. We don't use the retroperitoneal. So the comparison in this study has some has used the two approach. two approaches: the laparoscopic, the retroperitoneal approach, and the robotic, the intraperitoneal approach. So it is not. I mean that the comparison is not very strict between the two groups. Yeah.
And how do you decide between which patient gets laparoscopic and robotic? Is it the patients pay for the procedure extra, or does everyone get assigned surgeon? And then how do you decide who gets which method?
It's a good question. As I presented, we have no way to do RCT because the cost of robotic is not reimbursed by the insurance. The patient has to pay for the cost by their own pockets. So we couldn't choose the patient, and we just asked the patient. We have the option of laparoscopy and the option of robotics, and who can afford to pay the robotic, he will decide the robotics. So we cannot make a randomization.
No, thank you. Wonderful talk.
Thank you.
Thank you both. Any other questions from the audience, please? Again, I'm asking our younger colleagues from Vietnam not to be shy and to get involved in the discussion. Who's going to break the ice? Okay, that's fine. Professor, may I ask? I mean, it is obviously your experience and the number of cases and overall is impressive, but I can see that you still report that in your robotic group there's less nerve sparing and also more positive margins. Is this why is that? I mean, I would expect, I'm not a robotic surgeon myself, okay, but I would expect that someone with such an extensive lap experience, once they get the more advanced device, the robotic tool, to get even better, especially from this point of view, especially from the the very accurate parts or the very delicate parts of surgery. So what's your view on that?
Thank you for the very interesting question. When performing a comparison of robotic and laparoscopy, at that time, as I showed you in one of my slides, there are two surgeon teams. The thing is that the surgeon, the laparoscopy team, because we have performed that since 2004, and we on the surgeon has fulfilled their learning curves many years ago. So they are very strong at laparoscopy. In contrast, the group, the team of robotic, there was only two surgeons who has performed more than 30 cases of robotic. So that means that the comparison between the two groups, the surgeon, the team of surgeons in robotic, there are some who haven't fulfilled the learning curve. So so that at the beginning of the surgery of the robotic, as I showed you in one of my slides, the number of nerve sparing technique is less because when practicing the robotic, we don't pay too much attention to the nerve sparing, and when a surgeon who has fulfilled his learning curve, and by then he could pay attention to the function preserving technique. so that you see that the rate of nurse sparing procedure and the rate of and the erectile function of the robotic is less than the laparoscopy. But in the subgroup of the robotic surgery where we perform the nurse sparing technique, the erectile function of the two subgroups were similar. And concerning the rate of positive surgical margin in the bigger than higher in the robotic groups, I think is also the question of fulfilling the learning curve, and I think it was at that time it's from 2000 we carried out the study from 2019 to 2020, and now on our robotic surgeon in our center, they have all fulfilled their learning curve, and I think the outcome now would be much better than at that time in terms of functional outcomes and oncological outcome.
Yeah, perfect. Thank you. I thought it was a learning curve bias. So we could obviously talk more about this, and we are grateful for your presentation. We are already a bit late, so we'll have to move to the next topic. And I am honored to ask Dr. Tan, who's also a very experienced surgeon, to start his presentation. Yeah, can you please unmute yourself and start sharing? You can share your screen and good.
Good evening in Vietnam, but good morning in the Europe, huh?
No, good afternoon in Europe.
Good afternoon in the Europe. Hello again, Dr. Reagan. We are very happy to be here to present the study in our center. And back to 18 months ago, we remember this January research for us to make friends with European School of Urology, and we know Dr. Reagan. And we have the short discussion about the joining program between Vietnamese and England training in urology. Very impressive, your proposal. And now I have the presentation about robotic surgery in for treatment of prostate cancer. We know in 2001, Bider and Bremer in Germany present the first case of robotic assisted radical prostatectomy. And after 15 years in Vietnam, Professor Chuyên, he leader of urology in Vietnam, present the first case of RIRP. And after nearly 1 year, he had 52 cases. And now, convention IRB had become the surgical standard of care for prostate cancer. And now the statistics number globally, we have more than 150,000 cases annually, and the outcome very good, and very low complication. In the Europe, prostate cancer with robotic assistance around 60 to 70%. Leading country in Germany, Italy, UK, and France. And the number in the US is similar, more than 85% prostate cancer treated with robotic assisted, and more than 100,000 robotic procedures annually. And the number of robotic surgery increased significantly. But with the popular choice for prostate cancer with robotic assisted, but with radical prostatectomy is better or not? Do we need to improve the preserving continent is the most important after oncology outcome, and positive cervical margin, erectile function, biochemical recurrent rate is the we mentioned about the technique to do radical prostatectomy. To improve the outcome of surgery, we have a lot of techniques to overcome the functional outcome after prostatectomy with the sling and hook technique. And luckily in 2010, and the governor and Boxieri in Milan, Italy, create a new approach for the techniques, sparing radical prostatectomy. They are invented by Boxieri. And we have 27 comparative study and 24 review published until 2023. They confirm the advantage of pressure-sparing radical assisted robotic assisted radical prostatectomy related to the early continent recovery. And this picture shows the center on over the world, and the red spot you see on the right picture. This technique popular in the Europe and Mexico and America. In Vietnam, I think in the near future we have the spot on the map. And the resist bearing radical assisted radical prostatectomy in 2020, this approach, this techniques, the first time present in the EAU guideline. At the same time, we have the first case with this technique. And the paper published in the Journal of Urology conclude that these techniques associated with the better immediate continent than anterior robotic assisted radical prostatectomy. And some information about the largest center in Milan is the New Guarda Hospital. They have more than 2,000 cases in 10 years with this technique. This is a very, very impressive number. And this techniques have in the textbook of robotic surgery for prostate cancer treatment. The resist bearing is made with the name in 1849 by under Adolf Resist. This area, the boxon, composed ovarian tissue, fat and placid of veil. This picture you see. Back to the theory of continent. Traditionally, continent, urinated continent from the bladder neck and voluntary sphincter. But now this theory changed because of the intakes of suspensory ligament, pelvic musculature, and the tension maintenance and centrally placed neurovascular bundle and accessory pudendal artery and the functional membranous urethral gland. This make the complex internal place to preserve the urinary continence after procedure of the rescue-sparing IRP. And this table compare the advantage and disadvantage between rescue-sparing and conventional IRP. In rescue-sparing, the anatomy approach is rescue-spare, preserve, and let them remain undisturbed. This technique had advantage of faster return of continence, better early urinary function outcome, and preserve pelvic anatomy. But this has some disadvantage because the technical challenging and risk of inadequate exposure to the protect aspects. And this technique may be less familiar to many surgeons. And the oncology outcome is comparable to
Okay, I found this on the web for compatible too. Check it out.
It has the good advantage about the urinary continence recovery very quick, after 1 to 3 months only, and the good result for sexual function recovery. And in classes IRB, this is very familiar with the surgeon, but it had some disadvantage about a slow continence recovery and early urinary incontinence and high risk of post-surgery complication. And oncology outcome, it had good oncological control and long-term outcome. And about the continence recovery, is made slower than rescue-sparing, and sexual function recovery similar to other approach. This we have some information about a comparison between rescue-sparing and conventional. Where this techniques we have to good surgical skill. The surgeon have to master surgical surgery techniques and proficient in rescue-sparing anatomy and refine technical to assess protect without disturbing the rescue space. And in this technique, we have to be careful in dissection with the neurovascular bundle to maintain continence and erectile function, and perform precise dissection at the apex and blend the neck to ensure oncological and functional outcome. And this technique have to be delicate technique, minimize tissue damage and preserve natural anatomical structure, and utilize flexible. Some surgeon needs to use a flexible robotic instrument to operate the difficult to reach area. This chef saw that took a placement we use in our series. This video very short. We demonstrate our technique for our series. After we inside very short excision of the peritoneum, where they check the space of the near of the vas deferens and seminal vesicle, and we dissect to reach to the bladder neck. This is bladder neck. We dissect the catheter with robotics assisted and careful dissecting. We can find out the bladder neck easily, and we preserve bladder neck. This is the step of dissect of the protect apex. After remove of the protect outside, we do hemostasis, and we do the anastomosis from bladder neck and ureter. very convenient with robotic assisted. And after that, we close the peritoneum so that it's very clean circle area. And we think with this technique, we don't need to do extraperitoneal approach for radical prostatectomy anymore. This video we saw the techniques of the bladder neck dissection. This is the connection between bladder neck and prostatist ureter with robotic assisted, very easier for the surgeon to dissect this area. At the beginning case, we very careful to do this step, but for the later case, we can control this technique with a good result. This image saw the ureter between bladder neck and prostate. This video showed after we inside the non-video inside, we reach to the lateral of the prostate. This very necessary to reach the bladder neck. Steps, so we do the bladder neck and ureter anastomosis. And we have some early result for this technique improvement. We have some paper, local paper in Vietnam, and we present our experience in the UAE in Sydney, Australia, last two years. And we have some discussion about our experience. And it's this paper we finished with the series of 32 cases, but now we have a 36 cases with the prostate volume from 20 to nearly 100 grams, and with the small size of prostate we use for the first series. And now with the experience we pre-decide prostate nearly 100 with the good result, and recent score from 6 to 7 and 50% with recent score more than 8, and clinical state nearly 90% local prostate cancer, 5 prostate cancer, and some recent series we stand indication for locally advanced in the CT3A, 12% of my series. And the operative time ran from 60 to 200 minutes. In the first case, more than 3 hours, but now with experience, we have the case just around 1 hour, and very acceptable estimated blood loss, and the length of stay around 5 days. Some case we have just only 2 days with the recent case, because we after remove the RAN catheter, we do the patient, we have the patient discharge early and return after 1 week to remove the urethral catheter. And this technique is so very safe procedure. We have just seven cases with complication with red Clavian needle, red in red 1 and 2, And this complication had a good result after conservative treatment. Oncology outcome, we have around 18% of positive surgical margin. This similar to other report. And the outcome of urinary incontinence, we have immediate after 14 days around 87%. After 1 month, 12%. It means we have 100% urinary incontinence after 1 month. This result very impressive. And this study from two typical study, we saw the positive surgical margin according to pathology state between T2 and T3. We compare with the two technique, convention RIRB and resist bearing, so that the no significant difference between two. And about the continent recovery, we have a two group: overall continent group A and complete continent group B. We saw that with the resist bearing have significant improvement of the continent urinary continent recovery compared to convention RIRB. About the sexual recovery, Watson Donker in 1982 so that if we preserve neurovascular bundle, we can recover sexual ability. And in the study of Garfinol and his team report that the potency recovery around 40% after first month. And in his series, they had the one patient experience a full erection after 1 day after removal of the catheter. Very impressive. But in this technique, we have some challenges. And the first is the patient with throat cancer after doing TURB. But with this patient, we do not increase the surgical morbidity. But they think that in the patient with post-TURB, we do radical resist-bearing radical prostatectomy. They have the longer operative times and worse urinary incontinence. And the number 2 challenging is the patient with locally advanced throat cancer. They saw that the positive surgical margin is similar between convention and resist-bearing technique. And the third challenging is the patient with prostate size very big. They saw that with resist-bearing RIRB, in a very large prostate size, more than 100 ml, may affect operating time, erect estimated blood loss, and immediate urinary continence recovery. For that, I have some conclusion about these techniques. We can do with 32 cases in Vietnam in 5 years. We conclude that this technique very challenging for the beginning, but with increased case, this technique very possible to good selection patient. Thank you for your listening.
Thank you very much. Very comprehensive presentation. Obviously I love the videos. I think everyone did. So questions from the audience, please. Again, please don't be shy. We are here as friends together to discuss, to learn from each other. I'm pretty sure there are... Saiful, go ahead.
Thank you, Dr. Tuan. Lovely presentation. Thank you for sharing. Just out of interest, who assists you for the surgery? Is it your registrar residents, or do you have dedicated assistants for robotic surgical cases?
Yeah. You asked me who asked me in the first case of this technique.
Or any routine cases. Who will help you this week for your robotic cases? Is it your urology registrars, your residents, or do you have special dedicated assisting roles?
Yeah, thank you, Mizat. Back to 5 years at the beginning, before we do this technique, my senior, Dr. Nguyễn Văn Khoa, I think Dr. Khoa will give some comment about the technique. He recommend the new techniques on over the world before EAU approve. He and me to study on the YouTube, and we prepare everything before surgery, and we're very careful. We are be careful with the first case. That case we choose very small size, and we do step by step. At the beginning, we are very afraid of ureter damage, but luckily we avoid significant complication. Dr. Khoa, and after that, Dr. Nguyễn Văn Khoa is a very good surgeon. He helped me from at the beginning until now. And now there are many doctors in my department help at me in this technique. And for some case recently, we can do around 1 to 1.5 hours for the complete procedure.
I think it is impressive, and we understand that. I think Saiful's question was mostly because we would like to compare, understand settings. So with us, when we operate, we have a trained, advanced nurse who is actually helping the surgeon. We don't have normally we don't have another doctor that helps by the patient's side. And I think Saiful was asking, how is it with you? Do you have a resident that helps by the patient's side during the operation? Do you have a junior doctor, one of your colleagues, or is it just you and some specialized nurse? Is it what we wanted to ask, Saiful?
Yeah, just who assists you on a day-to-day basis.
Yeah.
Thank you.
Thank you.
I have one comment concerning the bedside system. In our center, we managed to have a system. Normally, the bedside assistant at Bình Dân, he is a young doctor. I know that in Europe, you have a trained scrub nurse who is very loyal to one consult surgeon. But in our system, we cannot choose a loyal or a dedicated scrub nurse who will work with the same surgeon all the time. But fortunately, myself, or I think the other surgeon in my hospital too, I can have maybe two or three young doctors who share my cases, and I only 2 or 3, and it's not the unique person who will work with you with all the cases. But I think with the young doctors, and you can work with maybe even 2 or 3 young doctors, and we are accustomed to each other. I think it's quite okay. Thank you.
Okay.
Thank you, Prof. Thank you.
Thank you. Professor Gnanapragasam, I think you got a question.
Thank you, Lorian. Thank you for these presentations, and it's interesting to see how you've set up and delivered a robotic prostatectomy in your unit. Prostatectomy accounts for only 14% of the prostate cancers managed in the UK. So the large majority of patients in the UK will not have prostatectomy. And I was curious to know what's the disease presentation of Vietnam in general, and also how you go about counseling about different options in your system.
Dr. Huang, Dr. Tuan, you can answer.
Excuse me, please, Dr. Huang, Professor Huang, answer the question, please. Help me. It's not clear.
Yes, thank you for your very good question. In our hospital, I think when we practice the robotic surgery, we find more and more prostate cancer generally, and more quite localized prostate cancer particularly, and according to the latest version of global count, actually the incidence of prostate cancer in Vietnam has maybe has double the incident since in the time interval of maybe 10 or 15 years. And when we began the robotic, we can, I don't know, maybe the incident has increased, and we find more prostate cancer, we find more localized prostate cancer. As I show you in my slide, we can operate on the patient with locally advanced, even CT3B, that's the cancer invasion into the seminal vesicle. We operate on the patient, and recently we could perform more the nurse-sparing radical prostatectomy because we find more localized prostate cancer, even the CT2 in that case is a good indication for a nurse-sparing technique. And in our hospital, the prostate cancer patient normally they go to see the urologist rather than the oncologist. And so in the department of in the urology clinics, urologists see the prostate cancer patient. And for your question of the presenting symptoms, presenting symptom is the lower urinary tract, lower urinary tract, and actually we just we don't have a national screening program based on PSA, and we just see the patient who consult for the urinary disease or other disease, and we screen on these patients who go to see the doctor, who consult the doctor, and most of the time they are symptomatic with the urinary tract symptoms, and some of them have no urinary symptom, but I think most of the time the patient consult for the lower tract symptoms. Yeah.
Thank you, Professor. Dr. Dontan, I think you've raised your hand. You've got one more comment. Please go ahead. You'll have to unmute yourself, yeah. Okay, maybe you don't have a comment, do you?
Yes.
Okay.
Follow the Professor Huang comment. I want to tell you about the picture of our prostate cancer detection. Before nearly 10 years ago, more than 80-90% of patients with prostate cancer come to us with the late stage, with the symptom. But now, nearly 5 to 10 years recently, with our program of early detection of prostate cancer, and I think the number of the early detection of prostate cancer around nearly 50%. The picture very, very bright compared to the past and compared to all the hospital in my country. Because in my hospital, we have the unit. We improve the techniques and procedure to do the prostate biopsy. And in my hospital, every day we have around 10 to 15 case biopsy every day with the very early stage with just increased BSA and very rare with the symptom. And that's the reason why the number of prostate cancer treated with radical prostatectomy increased significantly in around 5 years recently.
Yeah, so that's really what I'm interested in, because actually in the UK, the number of men proportionately receiving prostatectomy is going down because of early detection, because most men don't need treatment, you see. And so therefore, I was curious to know how that was happening in Vietnam, but maybe that's a bigger discussion for another day. Thank you very much.
Thank you.
Thank you. Thank you, Vincent. Thank you, Dr. Doan Tan. It is quite an interesting and big discussion, and it's basically a change of paradigm that, you know, what we are going through within the last years. I think rightfully so within the last years in the UK, but we would be more than happy to, you know, arrange something or discuss on this topic at a later date. We are quite late. We'll have to move on with our program. And I'm grateful to Sabrina Rossi, who is one of our brilliant colleagues, who's going to talk about this time about prevention mostly, or screening for kidney cancer, and how can we, she will give us an update or what's the situation here. So Sabrina, so Dr. Doan Tan, can you please unshare your screen? Thank you. Sabrina, can you please share your screen?
Perfect, thank you. Can you see the slides all right?
Yes, thank you.
Fantastic. So as Lauren mentioned, I'll be giving an update on screening for kidney cancer. So first of all, what are we going to cover in this presentation? Why should we screen, how to screen, and who to screen? We know that the disease is often asymptomatic. In fact, 23% of patients have metastases at diagnosis, and the late-stage diagnosis remains a key contributor to poor survival outcomes. We also know that the incidence of kidney cancer is increasing, and we hypothesize that earlier detection could improve survival outcomes. We also know that there are a number of drugs that are used in metastatic kidney cancer, which are extremely expensive. You can see this paper was published in 2017, and all the drugs cost around £30,000 to £60,000 per year. And since then, we're using even more expensive drugs. So the first line treatment is currently nearly £100,000 per year. And we know that 70% of patients who have metastatic kidney cancer will actually receive this therapy. Now, these patients are living longer and longer, making an even higher cost to the NHS. Comparatively, if we were to catch the disease earlier and offer these patients surgery, the surgery itself is quite cheap. It only costs £3,000. So the hypothesis is that screening for kidney cancer could not only help patient outcomes and improve survival outcomes, but it could also be cost effective. And in fact, screening and earlier detection of kidney cancer is a research priority. And we can see this in different publications in different years from different countries. We also know screening is a hot topic. So in the US and the UK, it's of strategic importance. The NHS long-term plan has a target to increase the detection of 75% of cancers diagnosed at stage 1 or 2, up from around 50%. And we're aiming to do this within the next 5 years. Also, Biden's Cancer Moonshot states that one of the 12 themes is to expand the use of proven cancer prevention and early detection strategies. So although it's really important for the government, we also know that it's a highly emotive topic for the general public. And every day we see articles in the Daily Mail and in the Sun, which are essentially either loving screening or hating screening and never somewhere in the middle. So really it is a form of Pandora's box. So if we try and think about screening for kidney cancer, what would be the ideal screening modality? So when we started our research project, supervised by Prof. Stewart, we thought of each of these in turn. The least invasive option could be a urine test, but urine dipstick is not very sensitive or specific for kidney cancer, as many patients don't actually have blood in the urine. Ideally, we could use a blood test, like circulating tumor DNA. However, the ideal biomarker has yet to be determined. We then thought that we could use ultrasound, as this is very cheap, it could be used in the community, and is relatively accurate if you compare it to the other tests mentioned so far. Of course, a CT scan would be even more accurate, but it's more expensive, costs more, has ionizing radiation, and is more difficult to use in the community. So we started off by using ultrasound as our hypothesis as a method to detect kidney cancer. So we ran a literature search and found that there were several studies that actually did screen for kidney cancer using ultrasound, but all the studies were from the 1990s, and they very rarely commented on survival outcomes, and none of them were randomized in nature. Despite this, we could use the data to run a health economic analysis, and this demonstrated that screening can be cost-effective in certain disease groups who have a higher prevalence. So for example, we can see that in females, it's not cost-effective, shown here in red, because the disease prevalence is lower. And in males who are older, it actually is cost-effective. So in summary, we can say that kidney cancer prevalence was the most important determinant of cost-effectiveness, and screening using ultrasound may be a viable strategy in some individuals. For example, we could combine this with people undergoing AAA screening, so aneurysm screening, which is a one-off at the age of 65. And if you were able to combine these two strategies, then it would be much cheaper for the health service and ideally could pick up kidney cancer earlier. However, we focused on the fact that to maximize cost effectiveness, we need to increase the group of individuals who have a higher disease prevalence. We know that there are certain phenotypic risk factors, for example, age, sex, smoking, high BMI, hypertension, diabetes, and family history. And these could enrich the group of individuals that we screen. However, these are not specific to kidney cancer. There are also a number of genetic risk scores, for example, SNCs and polygenic risk scores. However, these are expensive and not yet ready for clinical use because they're not quite accurate enough. And therefore, these limit the accuracy of any risk model that we could use. However, we did notice that there are some shared risk factors between kidney and lung cancer. In fact, patients undergoing targeted lung cancer screening have a 1.6 times higher risk of kidney cancer. So we hypothesized that we could screen for both diseases at the same time as a cost-saving exercise. We then ran a patient survey and asked individuals from the general public what they would prefer and what kind of screening mechanism would be their preference, and if this would affect the intention to attend the screening outcome in the first place. So we can see here that the options included a urine test, a blood test, ultrasound, an isolated CT scan to just look at the kidneys, and a CT scan to look at the kidneys and the lungs combined. And we can actually see that overall there's a high intention to attend screening. This is something that patients really want to do. However, the most favorable option is to screen for kidney cancer and lung cancer at the same time. This then led us to do the first trial of screening for kidney cancer at the same time as lung cancer. So for those of you that might not be aware, currently the NHS has actually approved screening for lung cancer for high-risk individuals. So in lung cancer screening, individuals are identified by the GP records, and they are offered a lung health check, which essentially includes an assessment of the different risk factors for smoking, age, gender, etc. And this will tell the individual the risk of lung cancer, and individuals who are high risk are then offered lung cancer screening. And this is done in these mobile health units. So essentially, these are little vans which go in Tesco's and Boots and city centres or parking lots, and they have a CT scanner on board, and they're able to screen individuals in a very convenient manner. So our study looked at the feasibility of adding on a CT scan after the individuals have had their chests done. It would then target the abdomen as well. And our aim was firstly to assess feasibility, but also to look at what kind of diseases we could detect. Who was involved in the trial? So this was done as part of the Yorkshire lung screening trial. So individuals aged 55 to 80 years with a smoking history who are considered high risk were then included in the study. And as mentioned, the research outcomes were the feasibility of running the trial, the prevalence data, the psychological harms, and of course, most importantly, health economic analysis. So I'm pleased to say that the results are actually published in European Urology. I've included the paper here in case anyone is interested. But to summarize, we had over 4,000 participants that were enrolled in the study. And the main finding is that screening is acceptable to the general public. It's also feasible. So scanning the abdomen will only add on an additional 13 minutes to the study. And we actually identified further strategies that can help reduce the burden on the NHS by reducing this time even further. We also showed that there is no psychological harm and anxiety associated with screening. Any harm is very mild and very short-lived. And lastly, we also showed that screening is in fact cost-effective, although this data is still unpublished. So you'll have to wait for the exact results. So if we look at the prevalence of findings, we can see that these little black men demonstrate 100 individuals screened. So we can see that the prevalence of a serious finding was 5.3%. Shown here with the red individuals. So this includes a 0.5% confirmed cancers, which includes 0.25% of kidney cancers, and the other split was other cancer types within the abdomen, and 1.5% of abdominal aneurysms, which are over 3 centimeters in size. And the remaining were other serious finding. Now, of course, this 1.5% AAA finding is quite interesting because in the UK, men aged 65 actually receive screening for aneurysms. So it is very interesting that we have an additional cohort of individuals who benefit from screening through finding aneurysms, which were either not detected on the normal screening program, or they were not eligible either because they were of the wrong age range or because they were female. We also find that there are some non-serious finding, these shown in gray, but these individuals, no further action was necessary. They just had an imaging review meeting and they were sent a letter to say that their findings were fine. And only a very small number of individuals had non-serious findings that required further investigation. So essentially, we are able to detect kidney cancers. And although we detect some incidentalomas, the burden on the patient and society is relatively low. And of course, this is why overall it seemed to be quite a cost-effective intervention. It's important to note that there are some key challenges in screening for kidney cancer and any research moving forward. Firstly, we need to improve the characterization of small renal masses. We know that at the minute, we could improve our ability to detect malignant versus benign disease. What we don't want to do is to detect large numbers of patients with benign masses who then have a nephrectomy or partial nephrectomy for something which did not need operating on. So we want to reduce overdetection and overdiagnosis. And ideally, we also want to detect and differentiate aggressive versus indolent disease, because we know that some cancers grow very slowly and could probably either undergo surveillance or avoid any surgery, whereas aggressive masses we want to intervene right away. As already mentioned, we know that screening may identify incidental findings, and it's important to quantify this to weigh up the risks and benefits of a screening program. Lastly, we know that risk stratified screening is a research priority. We know that the majority of kidney cancers occur in people who are deemed at low risk, and therefore they're not invited to screening. So we need to perform more research to find specific risk factors, potentially biomarkers that can help us identify individuals at higher risk. Lastly, it's important, as I already mentioned, to do research into the cost of screening and the harms of screening and how the process itself could be streamlined. So in the future, we'd like to explore more risk stratified screening options, determine accurate risk scores. As I already mentioned, look at potential liquid biomarkers. You'll have seen in BBC News that the NHS is currently looking at the Gallery test, which is looking at circulating tumor DNA methylation, and whether this could be used as an adjunct or if there are other biomedical biomarkers that could be used. This is something really interesting that we need to do more research in. And lastly, we're planning a study in the future which will specifically look at the feasibility of randomizing individuals to receive screening for kidney cancer and other abdominal conditions at the same time as having screening of the chest, the feasibility of recruiting these patients, and whether this has any impact on attendance to lung cancer screening. So lastly, I just want to finish by highlighting how big the research team is and thanking everyone who's been part of the project. Yeah, let me know if you have any questions.
Thank you very much, Sabrina. Very, very nice summary. I think this is a very important topic and something that we really have to look into, and not just about kidney cancer, but overall about how we did earlier, how we detect cancers on an earlier way, and you know, should we or shouldn't we do screening? Is that actually really helpful for healthcare systems overall? So, any questions from the audience, please? May I ask then, is there any screening program in urology, not necessarily in kidney cancer, currently running in Vietnam?
No.
There isn't.
Yes.
There?
In my country, we don't have the program of kidney cancer screening, but we have in some population they have a good economy, so they have the regular health check, and we have the ultrasound, abdominal ultrasound, always in the bucket of the health check. I wonder if with the good ultrasound is enough for kidney cancer screening or not.
Yeah, I think definitely it would be good enough. And especially if the ultrasound is being done for another reason, then it would make it more cost effective. I think when it wasn't cost effective for women, it wasn't that the ultrasound wasn't good enough. It was more that we didn't detect enough cancers because the prevalence of disease is lower in women, which is why we were then interested in looking at higher risk groups.
Thank you.
Thank you.
But may I come back with the same question? Is there any other screening program on any other urological cancer running in Vietnam? Prostate, bladder,
No,
whatever? No.
no.
Are there any plans? Because you know you're one of the biggest centers, and if something like that is planned, you would obviously be involved into. Are you aware of any plans to do something like that, or do you think it would be useful, or would it be something that can be done in the socio-economical conditions of your country? Because obviously things are different. They are different compared to my country where I was born. I used to work compared to the UK, and obviously Vietnam is a different setting. So do you think this would be something that should or could be done in your country? Not specifically kidney cancer, but
Yeah, so maybe more than 10 years ago, there is a senior professor, Professor Vũ Lê Chuyên, that Dr. Toàn mentioned in his presentation. More than 10 years ago, he conducted a prostate screening program. But in his program, he screened using the PSA for prostate cancer, but it's not a population screening, but it's a kind of targeted screening for prostate cancer, concentrating in the as I mentioned before, we concentrate on the patient who come to seek medical advice at Bình Dân Hospital for urinary symptom, or not for urinary urinary symptom, and after that. Nationwide, we don't have any national cancer screening, but even in each individual center, it has its own screening program, but not very often. For comments of the presentation of screening in Great Britain, I see that the idea is quite new, and in Sabrina presentation, he mentioned about the risk patient who has some risk factors, but I think the correlation between for example, the correlation between the lung cancer and kidney cancer is not very clear, and I have got no idea about screen the patient with lung cancer, and with using the CT and put another shot on the abdomen to screen the abdomen, but in my experience in Vietnam, I repeat, there is no screening program at all, but we have we use the ultrasound to detect the small kidney tumors, and when we find small kidney tumor, it could be a benign or malignant tumor, but ba đang họp đừng có gọi, ba đang họp đừng có gọi, ba đang họp. Sorry, I have a phone call. And when we can detect a small mass, a small renal mass, it could be a benign or a malignant lesion, and we can observe the tumor, or we can perform a partial nephrectomy or even a tuberectomy. And I think for the screening of the kidney tumor, I have the same idea with Dr. Toàn. I think ultrasound is good enough. No need for the CT. I find no benefit for the CT in this scenario. Thank you.
Okay. Yeah, I think, I was listening to you. I was thinking that there's room for collaboration and research on this topic. So probably we will when we discuss later on, Professor, we can identify some ways that we can do things and collaborate. Now, any other Professor Gnana Prograsam has a question. So Vincent, please go ahead.
It's just a really quick question. In Vietnam, what is the most common cancer that you see? And as a proportion of all cancers in Vietnam, where does urological cancers, prostate, kidney, bladder sit? So effectively, is it a priority, urological cancers, in terms of Vietnam's cancer burden, if you see what I mean?
Yeah. In Vietnam, the significant cancer depend on the gender and the age. For example, for the men, the lung cancer is significant in the man after 40 years old, and in the woman get married, cervical cancer and breast cancer is the predominant cancer in Vietnam. But the exact number we don't have till now. Yeah.
Okay.
Yeah. According to I've got the Global Count 2022 in Vietnam. The most common cancer is the lung. After that, the liver. Thirdly, the stomach, colorectal, and the prostate is number five in incident. And the incident in recent years in prostate cancer is around 11 per 100,000, and between men and women, as mentioned by Dr. Toàn, in women, women the breast is the most common cancer, and actually we don't have any priority in screening of any specific cancer in our center. We have no national program, and each center, as I told you, each center has its own strategy to detect and to screen the cancer they treat.
Yeah, yeah. So actually quite a different profile from what we have in the UK. So I guess prioritization is the priority of which cancer is also going to be different, isn't it?
No priority.
Yeah.
Good. Thank you very much. Thank you again, Sabrina. We'll move ahead, and I will ask Dr. Dolen Hung, who's here with us. I can see you. Thank you for joining the meeting, and thank you for accepting to prepare a lecture on your hospital or your how you manage the urethral strictures. Can you please share your screen?
Okay, I'm going on it. Okay, right here. Can you hear me?
We can hear you, yes.
Okay,
And
so
we can see. Yeah.
okay, so hello, Dr. Drokos. Nice to meet you again here. So today I'll be talking about urethral stricture and how we manage it at the hospital, also in Vietnam. So talk all self-training, and the success rate at the moment worked around 60 to 70%, and most of the patients have to suffering from dilation after surgery. So we had an opportunity that in December 2014, Professor Joe Gelman from UC Irvine Medical Center came to us by the IVU Med. And then I had a chance to visit him for a 4 month fellowship program at the UC Irvine Medical Center, which is 2 visits, so totally 8 months. And then when I got back home, we established the urethra unit in June 2015. And we keep having the training and cooperation with Joe Gelman from UC Medical Center. And so far, it's been more than 9 years. And we at the moment we have the donation of equipment from Gelman, and right now and the exactly same setup with UC Irvine Medical Center. So this is what we are using for urethroplasty. This is the whole set of the equipment, and this is the whole set of the what called the Jordan Bookwonder perineum retractor. We also have this donation, and this is the first flexible scope donated by Professor Gelman. But right now we have plenty of flexible scope and very popular, especially for all the male patients. When we do cystoscopy, we just use the flexible scope. And we keep cooperating with Professor Gelman. So annually, he keep coming to us and doing like 2 week visit. We are doing live surgery for the 2 weeks and mostly 2 cases a day. And he always bring his fellow and his resident. And we also invited some doctor from the other country, especially from Asia. So far, there's been some friends from Hong Kong, Australia, Malaysia, Thailand, Indonesia have been visiting us. So this is our review. So from July 2015 to actually this year, so there were over than 2,500 urethroplasty cases performed at my hospital, mostly 4 to 6 cases a week. So the most common cases is the posterior urethral stricture, with around 1,086 cases, consist of 43%. And in those cases, so there were 80% of the PFUI, which is the have the pelvic fracture, and we have a lot of redo cases. It means that the patient had reverse surgery and they all failed. Some patient could be like 2 or 3 or 4 redo and then came to us, and their a prevalence of the anterior redo case is around 28% and the posterior around 12%. And we have all the etiology of the urethral stricture in our country. But the most common reason is the pelvic fracture caused by the motorbike accident and the working accident. So before doing surgery, the patient need to have some requirements, which is the urethra need to be at rest for at least 3 months with no intervention. And then they need the suprapubic tube, which is at the midline and 2 finger breadth above the pubic symphysis. And we all control the urinary infection by the urine culture. And for evaluation of the stricture, we first do the cystoscopy using the flexible scope and then measure the meatus of the patient by using the Pucci. And when we do cystoscopy, if we see the stricture just like the image shows us here, and then we will go on to do the drug and the VCG. This is how we do the drug. So we will use a gauze diluted with the contrast, and then we put at the gland, and the gauze will have to point us where the fossa is. And then we inject the contrast into the urethra by using the adapter, as you can see at the image here. And this is what we have on the drug. So as you can see, this is the gauze diluted with the contrast here. So it points us where the fossa is. And after that gauze is the penile urethra, and then the vulvar urethra, and then this is the area of the sphincter, and after that it's the area of the prostatic urethra. And then we perform the VCG when the patient feel like full and they need to urinate, and then we let the patient urinate by themselves, and then we have the image of the bladder and the bladder neck open and the posterior urethra open. For some special cases, like the patient who is unable to urinate, or they have the obliterated strictures, or especially at the redo cases, we will perform our special technique, which called the above and below urethral graft. That is how we do it. So we will have one doctor to use the flexible scope to put into the SP tube hole, and then scope the patient into the bladder, through the bladder neck, and then all the way to the stricture. And then he will stop the flexible scope there, and then inject the contrast through the flexible scope. And then we have the other doctor doing at the same time the drug from below. And then we take the X-ray at the same image. And this is the example. We will see the bladder here. This is the flexible scope, and then the posterior urethra. And we also see the anterior and posterior urethra at the same time. And that helps us to measure how long the stricture is, and where's the posterior, where is the distal and posterior part of the urethra. And this is what we have here. This is a redo case. The patient had reverse surgery that the doctor at the moment connect the urethra to the bladder wall. And with the flexible scope into the bladder, going through the bladder neck all the way to the stricture, we will see where the posterior urethra exactly is. And then we can recognize this is image. And this is how we, this is another example of technique above and below urethral graft. We will see the whole, the posterior urethra and the anterior urethra at the same time, as you can see here. This is another example of the fall passage in a redo cases caused by the reverse surgery, failed reverse surgery. And this is the area of the posterior urethra. And this is the area of the fall passage. And we perform all type of surgery using for urethroplasty, for example, the EPA, the excision, and primary anastomosis, transected and non-transected. And then the buccal mucosa graft could be dorsal or double face or stage repair. We also do the onlay penile skin flap in special cases. The dorsal buccal graft versus the penile skin flap in complicated cases. And for some special indication, we will do the periosteomy for like severe and really old patient. And some patients just a simple technique like BA-otomy. And how we follow up the patient. So all the patient will need to come. We need to come to see us at 3 week post-op. Then we will do the VCOG for the patient, just like this case that I mentioned before. This is how we connected the urethra. This is how the post-op image. You can see that is connected. And on the VCOG at 3 week post-op, we just look if there's leakage or not. If there's no leakage, we will remove all the catheters. In case there's still like mild leakage, we can also remove all the catheter, or we just remove the urethral catheter and then we leave the SP tube for like a week, or we sometimes we will put the 14 French Foley catheter into the urethra again and leave it there for 1 more week and keep doing the VCOG at 1 more week post-op. And all the patient need to come back to see us at 4 months post-op, and then we will do the cystoscopy to confirm that the urethra is wide open. And if the urethra is wide open at 4 months post-op, we will confirm the technical success rate. And after that, the patient needs to come back to see us for off with us every year, and then we just do the RUV and the uroflow annually. So how we define success? For us, success is the technical success is the urethra wide open, looking and confirmed by the flexible scope, no dilation ever and ever. And the long-term success, it means that the urethra stays wide open, no symptoms, no need for treatment ever. And if the patient ever needs to be catheterized or dilated, that is failure. So, and this is our result. The success rate for posterior urethral stricture treatment of our data is 98%, and we also reported published this data at the AUA meeting. For the anterior, for the buccal mucosa graft, the success rate was 91.4%. The EPA, the simple EPA, almost 100%, or the periostomy over 100%. We still have some like failure, like fistula for the skin flap, but it's just like mild cases because we don't indicate the skin flap are common. And what is our future objective? We would like to be a training center, and so far I think right now we have the owner set up to be the training center of the country, and also training center for the doctor from the other country, like in Southeast Asia. And there were some doctor from Malaysia and Indonesia contacted with me to be visiting us and doing the fellowship for at least 6 months. And we will publish more data at the international conference presentation. And thank you very much for your listening.
Can you hear me?
Yeah.
Perfect. Thank
Really?
you. Thank you. Wow, that was very nice, instructive lecture. I loved it, and I think it was quite useful, especially for our younger colleagues. And I would really like to get some of a comment or a question from our younger colleagues from Vietnam. But let's open the topic for discussion. Any questions from our side? Costa, perfect. Thank you. And Sabrina, thank you.
Hello.
Hello.
Yeah. Go ahead, Costa, and then Sabrina.
Yeah. So it was a really nice presentation. I was just wondering if they actually have any experience with the drug-coated balloon urethral dilatation. It's just like Optilum that uses paclitaxel. If they have any feedback regarding that, and if they have actually tried it.
Excuse me, can you repeat your question, because the internet have some problem?
Yeah,
She
sure.
was asking if you have any experience with balloon dilatation with the Optilum device, with paclitaxel, or something similar. Is there something similar in Vietnam or in the close proximity in your region? Are you familiar with this?
Actually, I'm not familiar with the balloon dilation. Or for some special cases like the stricture at the vulva area, less than 1 centimeter. For the first time, we still do the DVIU with no dilation, and the success rate was confirmed to be around 60 to 70%. And if that DVIU failed, and then the next would be open surgery.
Okay, thank you. So Costa, why don't you briefly tell us a bit about Optilium?
So it's actually a big trend here. I think that it's mostly the company that brings it to the country that tries to push it forward. And we see that many urologists, especially in the private sector, in order to avoid any urethroplasties, they tend to do at least 1 or 2 sessions of urethral dilation. And there are some studies, I think there is also a study called the Robust trial, something like that, that shows that especially in anterior urethral stricture, there is some benefit. But we do not really have much experience with that. So I was just wondering if they had in their hospital, since they got really many patients and probably more amount of cases than us.
Yeah. Okay. Fair enough. Something to consider for future collaborations. Sabrina, please.
Yeah, I was very interested by the topic of potential exchanges, because you mentioned that you've got lots of cases and lots of exposure, and that perhaps trainees from the UK could come. So yeah, I was very interested to hear more about that.
Yeah, well,
Sounds like a very exciting prospect.
Actually, this is one of the things that we will probably start some form of collaboration one way or another. It's in our plans to build some projects together.
Yes, sure.
Yeah, that'd be really great. As a trainee, I think it would be really great.
Yeah. Any other comments or questions? Paul, please. Thank you.
Hi. Yeah, it's brilliant talk. Really interesting that. And the amount of surgery you're doing is really impressive. I just wanted to hear from your perspective how your training in the US was, how useful you felt that was. Would it have been useful to have done more, or did you feel like you got everything you needed from that trip there?
Okay, so actually, I've been into the US for 2 times for 2 visits. For the first visit, 4 months, I've just learned how to do evaluation of the urethra, like how to do the X-ray, how to do the drug, how to do the VGG, how to evaluate the patient. That's it. And then I came back here and prepared the patient for Gelman to come to Vietnam, and then he will be doing surgery. Give me the hands-on training on my patients. And every trip for 2 weeks, and every day I will schedule up to 2 cases. And so far it's been like 9 years working together, and 2 weeks a year. And every time we can do surgery like more than 10 or 12 cases. And without him, I have to do surgery by myself, and like 4 to 6 cases a week. So what you learn from the expert, and then you apply it to your practice, you get experience, you get explore, and then he came back again, and then he fixed our technique, and then I learn and keep learning more from him. So our fellowship program just like a very special program, and it's could be the longest fellowship program ever. It's been 9 years.
It's very nice. Thanks for the question. It's very nice, and mentorship and collaboration and learning from each other is quintessential. It's basically why we are arranging these meetings, to know each other and to start projects together. Hopefully this is going to be the case. We thank you very much again. We will have to move on, and I will invite Costa, who used to be with us until very, very recently, when he got back home to Athens, where he is a consultant urologist. So Costa will tell us a bit about how things are in the UK or in Greece compared to the UK. So Dr. Hung, can you please unshare your screen? Thank you.
Nice.
You
Hello.
can start.
Yeah, let me share my screen. I hope you can see my screen.
Yes, we can see your fancy presentation.
Yeah. So, hello everyone. Before starting, I just want to say a huge thanks to Mr. Dragos for inviting me. And it's also really nice to see all those familiar names and faces. Sabrina, Paul, Odette in theater who is actually attending. It's really nice and it feels really warm in my heart. So I will just try to explore how two different healthcare systems, the NHS in the UK and our national health system in Greece, have responded to challenges so far. We've got the logos, same colors, UK and Greece, the blue. We're gonna see if we actually managed to recover from all those issues that we had so far. And by starting, let's compare these two systems. The NHS was established in 1948. It's a universal, publicly funded healthcare system. It's free when it comes to the point of care for the residents of the UK, and it's funded primarily by taxation. The NHS is structured into separate administrations for England, Scotland, Wales, and Northern Ireland. In Greece, our national health system, which is called the C, was founded in 1983. It's quite recent, and it also offers a universal health system as well, but it incorporates a mix of public and private care. Citizens have access to free or low-cost private services through public hospitals or private sector, and they try to do that in order to get faster specialized treatment, which is not offered in the public sector. We still have high reliance on the private care, and this is actually a sign of the inefficiencies that we still have to face in the public system. The NHS is entirely funded by general taxation with just minimal out-of-pocket expenses for the residents of the UK. This only applies probably to prescriptions and dental care. In contrast, in Greece, we have to pay for medication. We have to pay for anything diagnostically done in the private sector. We still have to pay for the national health system through taxation and through social security. And if we compare the sizes of funding, the NHS gets about 10.2% of the UK GDP, while Greece only spends 7.8% of the GDP. And all this taking into consideration that Greece is a small country, which is actually smaller than London itself. So both systems claim to offer a universal healthcare, but the accessibility differs. In the UK, all the residents have high access to primary care throughout a robust network of general practitioners, the GPs. In Greece, the access is less consistent, especially in rural areas, the mountains and the islands. Their patients have to wait longer times, and sometimes they need to seek private care to avoid delays in Athens. They have to travel here. Non-citizens in both countries can access emergency care, but in Greece, sometimes non-residents have to pay in advance for the care that they're going to receive, if we actually find a way to charge them, because we've got many administrative issues. In the NHS, the time for specialist services are long, but generally the system is more accessible than in Greece, where we have to wait and we have to find a way to fix this gap between the public and the private sector. The life expectancy when comparing two systems in the UK is 81 years, similar in Greece. Overall, the healthcare access is ranked higher in the UK, but the score is practically the same. The satisfaction varies when it comes to the system for both countries. Maybe people in the UK are generally more satisfied, but in Greece, people prefer to attend the private sector because they feel that maybe the services offered in the public sector are not as good enough. The main problems for the NHS, the main challenges are probably the aging population and the increased demand for healthcare, especially when it comes to cancer or chronic diseases and the elderly care. There are also important workforce shortages, which are a critical issue as well. And there are also some gaps when it comes to nursing, the GP positions, and specialists. When it comes to Greece, we still have funding pressures. Here we are. And all this has really been impacted by the recent economic crisis that started in 2008. We still are having trouble to find finance to support the services that we offer. Our hospitals are mainly understaffed with lack of services, especially in rural areas. Still, as I said before, people have to travel to Athens to get more advanced care. For this reason, we try to engage more the private healthcare sector, but this can lead to disparities because not everyone has the ability to offer those extra money to get the care they need. And additionally to that, many Greek doctors have migrated abroad. They have left the country in order to get better training opportunities and working opportunities. This is what we call a brain drain for Greece. We have been trying to reverse that, but still the gap between young and older doctors is really noticeable. And that's because older doctors have remained in the country, while younger professionals just left the country in order to seek a career abroad. Looking ahead, both countries have initiatives aimed at improving their healthcare systems. In the UK, probably the government has pledged to invest more in the NHS, even though it's already investing too much money. And they also try to reduce waiting times through novelties like digitalization and telemedicine. It's something that we do not apply in Greece. We do not even have the infrastructure to support something like that. However, sustainability of the NHS is still a concern, and especially as costs continue to rise and population ages. In Greece, we try to make reforms and implement a reduction of those out-of-pocket costs in order to improve the efficiency of the public service. The government is also working to strengthen the primary care services, maybe introduce some GPs, but so far it's something that we cannot really manage to do. We still have to heavily rely on the private healthcare sector in order to proceed with many operations, many investigations, and get simply the job done. When it comes to training, both countries offer a high standard of training, even though the pathways and the experiences when it comes to training are quite different. In Greece, medical school is highly competitive with a focus on the theoretical knowledge. After completing medical school, we have to wait for a long period of time before starting residency, sometimes several years. And this, in the long term, can push many Greek doctors to seek training abroad, mainly in the UK, in Germany, Switzerland, and Belgium. On the other hand, in the UK, medical schools are also really highly competitive, but the system seems to be more structured. It includes exams, interviews, and competitive curriculums for all the students. After graduation, students enter a 2-year foundation program, and then they begin their specialty training. The competition for residency is really tough in the UK, but there are fewer delays compared to Greece. The only bad thing is probably that the overall training time can last significantly longer. Now, I would just like to share my personal experience at Addenbrooke's. I only spent like 9 months there, but it was really a life-changing experience. From the moment that I arrived, I was really impressed on how well everything was organized, how efficient the hospital felt. Even though there was the main wing of the hospital, then there was also the Addenbrooke's Treatment Center and its theaters, which was a really modern and really nice place to be and work, with really nice spacious bright rooms in the ward, large corridors, easy access for everyone. Everything was clean and clear. Everything was taken into consideration when they built this place. And all around the corridors, you could see the medical history of Cambridge and the achievements of this university and hospital. I never felt like an outsider in this place. Everyone was really friendly. The consultants were really approachable. There were many consultants as well, something that we've not really seen in Greece. They were all happy to explain every procedure, and they will always want to give you a chance to take an initiative when it comes to treating a patient. And everyone seemed to be really professional and really, really kind. When it comes to the nurses, something completely different came just before my eyes. Whether it was the cancer care nurses, the stomach care nurses, everything was really impressive. It's something that we do not have as a service in Greece. And it seems that these highly specialized nurses can really attribute to have great patient outcomes. The operation theater was great as well. Everything worked really perfectly. We had some delays. This can happen in every theater in the world, but still everyone was following strict protocols. And when we had really challenging procedures, we always had the way finding the necessary equipment, and we were able to plan ahead and do whatever was actually needed. In emergency conditions, Addenbrooke's was amazing as well. A&E, despite the delays, was working really nice. You were always feeling safe that you can deal with any urgent case in theater without having to negotiate much with the anesthetists or try to persuade someone that you need to go to theater. And apart from all the emergency cases, what really works well in Addenbrooke's and in the UK as well is the 2-week wait pathway, which is a pathway to deal with cancers. It's really impressive because it provides a fast way of dealing with patients with suspicion of cancer, offering clear instructions, a clear algorithm, and then there is a robust follow-up system that never allows anyone to get lost in the process. So let me say just a few things about my teachers, the Stone team guys, my personal Mr. Miyagi's. So the Stone team was, for me, the best team of the hospital because they really deal with some of the most complex stone urological cases, and they all got amazing skills. And at the same time, they remain really humble and kind with everyone. They do multiple surgeries each week, and they have the chance to have access to all the latest technology. We do not have that. We only have to deal with a whole new laser of 60 watts. While in Cambridge, they've got Moses, they've got the TFL, they've got everything. They were all really generous when it comes to sharing the knowledge and offering teaching and additional training. Even though the hospital doesn't really seem to understand what they're offering, I believe that their contribution to the community is really great because under their care, I have seen the management of cases that were really complicated, actually the most complicated cases that I have seen so far. And it really takes nerves to deal with cases like that. For me, I don't know, I feel that I can easily say that I have not only gotten better medically, but by leaving this place and after working with this specific team, I have gained great friends and great mentors as well. So this was for me the biggest plus from spending some time with the Stone team in Cambridge. I don't want to delay you anymore. Probably this is the only thing that really works in Greece. Sun, sea, maybe the summer, and some good food. Addenbrooke's is a great place to work. There are many complaints about the NHS, but you always have to put in perspective what things are like in other places of the world. So no one should complain. You should all be happy with what you've got. And yeah, a huge thanks to the Stone team in Addenbrooke's, and especially to Mr. Dragos.
Thank you very much, Costa. Quite enthusiastic as usually. We really liked when we love to have you when you are here. I wanted your talk to be included in our meeting because it puts things in perspective. It shows to our friends and colleagues from Vietnam that in Europe it doesn't mean that things are the same. Even in the UK, things are different from hospital to hospital, but there are this. It may be a bit of a different optic, and the comparison that you've put together, Greece versus the UK, shows how national healthcare systems work. And maybe, we've got young doctors here with us today. They will change the future of medicine in their country, and they will learn how to look into different models and how to make things better at their place. So I think it was quite useful. It was quite instructive for me as well, for all of us, I hope, and I'm really grateful that you did it. And obviously, thank you for being here. Thank you for working with us. It just comes very nicely in line with the fellowship topic that was addressed by during the previous talk. I think this is the way to go ahead, to work together, build things together, provide help and care and mentorship, and this is in the end what's going to help our patients. You can only operate with two hands in the end. You can do probably a few thousands of patients, you can help them during your career, but if you teach someone, and if that person understands the importance of teaching and passing knowledge, then you will reach 10 times, 50 times more patients, and this is what we want and need. Thank you very much again. Any questions or comments for Costa? Okay. If there isn't any comment, or if there isn't any question, I think we can conclude and finish the meeting today. Thank you very much to everyone attending. I hope you enjoyed the meeting. I hope you've learned from it. We definitely did. I did. I'm looking forward to future collaborations with our colleagues and friends in Vietnam. Hopefully, we'll manage to do some projects together. Remember, we should always look at each other as to a colleague, to a friend, and if there's anything that we can do or in the future, don't hesitate to contact us. If any of the young urologists attending want more guidance or help, feel free to contact us. On the other hand, the same way for our colleagues or our junior doctors. If you would like to get in touch and start some collaborations, don't hesitate to let me know, and we can start things. I think this is it. I was really looking forward for this meeting, and I really enjoyed it. Hope it was the same for all of you. Thank you very much. If anyone else would like to add something, please do. Otherwise, we will just finish the meeting.
Group photo, please. Yeah, you saw the picture and group photo, please.
Yeah. If you can turn your cameras on, that would be a good idea. Thank you. Well done. Yeah.